Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy professional life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to have with me today in the studio my colleagues.
I'm Rhiannon Ashman.
And I'm Dawn Liz Powell.
And today we're going to take just a sample of some of the emergency presentations that you might see in general practice. The list of emergencies that you might encounter is potentially quite long, so we're going to cover just some aspects that are covered in our learning modules on the site. As you may or may not know, we have a long-standing series of red flags modules that deal with symptoms and signs that may suggest a potentially serious cause of a patient's symptoms. So first off, we'd like to mention a couple of those in this context. So, chest pain can have life-threatening causes. Our red flags module on chest pain highlights myocardial infarction, aortic dissection, pneumothorax, and pulmonary embolism in this context. And as Dr. Pippin Singh points out in this module, red flags symptoms to look out for include a sudden onset of chest pain, hemoptysis, pain occurring on exertion, and a history of long-haul flight or period of immobility. And the NHS advises that patients should call 999 if they experience sudden chest pain that doesn't go away, and or spreads to their arm, jaw or back, and if they feel sick, lightheaded and short of breath.
Yeah, I think don't mess about with sudden chest pain. I mean, it's fundamentally better to call an ambulance for what turns out to be a panic attack or something else that isn't life-threatening than the other way round. But just as a reminder, we do discuss that red flags modules on chest pain in our episode on stable chest pain. But as the name suggests, that focuses on chest pain that is not an emergency.
Yeah, and another emergency you might see that's covered in one of our red flags modules by Dr. Sunita Kochhar is epistaxis or nosebleed. So 90% of nosebleeds are anterior nosebleeds, whereas 10% are posterior, and this latter type is more common in older people. So if you're seeing this in clinic, active bleeding needs to be stopped, and with an anterior bleed, pinching the lower part of the nose for 15 minutes can stop the bleeding. The patient should be sat upright during this, and once the bleeding has stopped, you can examine the nose and consider cautery. A posterior bleed might need specialist management though, with packing or compressive balloons. And red flags related to epistaxis include bleeding that's not stopped by direct pressure, hemorrhagic shocks, signs suggestive of a bleeding disorder, or use of anticoagulant therapy.
Yep, as a veteran of many a childhood nosebleed, I can vouch for methods that do and don't work, and certainly pinching the nose firmly is the way to go.
Of course, any type of bleeding that's not stopping could be an emergency or certainly require urgent care. And actually, another module that this is covered off in, for example, is our red flags on heavy menstrual bleeding, where the author explains what amount of blood loss would be considered exceptionally heavy and drugs that can be used to stop that bleeding.
Thank you. And that's just a brief look at just a few of our red flags modules. Obviously, we have many more. Moving on, we have a mixed bag for you, which reflects the mixed bag of potential emergencies you might see. We're going to look at anaphylaxis, back pain, and emergency contraception. Bearing in mind that perhaps it might be good to return and cover some more emergencies in subsequent podcasts. So let's start with anaphylaxis, which is sometimes unfortunately in the headlines and may rarely occur in GP surgeries because of reactions to immunisation. Just to be clear, we're talking about anaphylaxis that takes place within the GP surgery, where you have access to drugs and equipment. Our module on anaphylaxis covers guidance, and it's written by a GP called Dr. Sonia J. She's done a really concise job of summarising the changes in the latest guidelines from the Resuscitation Council UK. The most recent guidelines are not actually all that recent, they're from 2021, but the previous version was in 2008, annotated 2012, so they obviously don't change all that often. She's listed on the first page of her module the key updates that relate to the current guidance as opposed to the previous version. So I'll just go through those quickly. Firstly, the new guidance emphasises that administering intramuscular adrenaline is the most important step in treatment of anaphylaxis, and it also stresses the need for repeat dosing of adrenaline in those who don't respond to the first dose. A dosage is now specified for children under 6 months, and regarding positioning, the guidance gives advice on the preferred posture for the patient, lying them flat with or without their legs elevated. It provides algorithms for the treatment of anaphylaxis and refractory anaphylaxis. It informs GPs of the indication for IV fluids, and interestingly takes out antihistamines and corticosteroids from the equation. They're no longer considered part of routine emergency treatment. Just to give a quick definition of anaphylaxis, the World Allergy Organization defines it as a serious, systemic, hypersensitivity reaction that's usually rapid in onset and may cause death. Severe anaphylaxis is characterised by potentially life-threatening compromise of the airway, breathing, and/or circulation, and these are called ABC features, and these may occur without typical skin features or circulatory shock being present. We've got a figure in this module which shows the spectrum of severity of allergy symptoms.
I'm interested in the skin symptoms bit, part of that definition. So how do skin symptoms relate to anaphylaxis?
They can be part of it, but not necessarily. And as the figure shows, you may have mild localised skin symptoms or generalised skin reactions that aren't anaphylaxis. That's when there are no ABC problems. Then it's not anaphylaxis. However, if you have ABC problems with or without skin symptoms, then you're looking at anaphylaxis. But Dr. J does say in the module that skin and mucosal changes may be present even prior to systemic features and may offer a clue to the diagnosis should the ABC features go on to present.
Yeah, that's interesting actually, because we did an episode recently for this podcast around dermatological presentations of systemic illness. So it's interesting that there's another one that the skin symptoms can present before the systemic symptoms. So a good clue.
Yeah, can be the telltale.
Yeah.
So it is interesting. Regarding other aspects of management, the guidance advises to remove the trigger if possible. If there's a bee sting, remove the stinger. If it's a food reaction, don't try and make the patient vomit. And don't delay treatment if removing the trigger is not possible. As an aside, there is a table with the common causes of anaphylaxis in the UK. And would anyone like to guess the commonest triggers?
Well, you've just said it, bee stings, and that guess is totally based on scientific evidence and not because it's a plot point in Bridgerton.
I did not have you down as a Bridgerton fan, Dawn. I'm going to say peanuts. I remember when my daughter was a tiny baby going to a baby class, and there was a mum there who had an older child with a severe peanut allergy, and the baby class happened to be very near to our local hospital. So she was doing like an oral challenge of her baby for the first time having peanut butter in the car park of the hospital, just in case.
Just for belt and braces. Yeah. And what was the outcome?
The baby was fine, I think.
Baby was okay.
Yeah.
That's good to hear.
Yeah.
Yes, so foods are the commonest triggers, and peanuts, tree nuts and cow's milk are very much the top ones. The second most common category of triggers is medicines, specifically antibiotics and chemotherapy drugs, with penicillins and cephalosporins also implicated. NSAIDs as well are noted, so it's worth having a look at the table about triggers in the module. So going back to the hypothetical situation where you suspect a case of anaphylaxis happening within your surgery, the Resuscitation Council UK have kindly let us reproduce 2 of their PDFs, which are really concise algorithms on what to do in anaphylaxis and refractory anaphylaxis. You can find these in the learning module, and we'll link to this in the notes under the podcast. So to summarise, when you encounter anaphylaxis, call for help. This is the really key step, and in primary care it means calling an ambulance. Then in most cases, lay the patient flat, with or without their legs up, but if there is breathing difficulty, put them in a semi-recumbent position. People who are breathing normally but are unconscious should be in the recovery position, and you should monitor their breathing. Where possible, gain IV access, as IV fluids have been integrated into the guidance. They're to be given if there's a poor response or no response to the first administration of intramuscular adrenaline and in the presence of hypotension or shock. GPs are advised to give a non-glucose containing crystalline fluid such as Hartmann solution when they encounter refractory anaphylaxis, and that is defined as persisting respiratory or cardiovascular symptoms despite 2 doses of intramuscular adrenaline. So while the ambulance is on its way, GPs should have established IV access, commence IV fluids, continue giving intramuscular adrenaline every 5 minutes, and administer high-flow oxygen. There's a key learning point section, which I think is really handy, that summarises all the changes that Dr. J has listed. And the module is really written from the point of view of a GP, which is helpful when talking about this potentially very serious emergency that you can come across. And just as a final point, there's a handy guide for GPs about auto-injector prescription for patients at risk of anaphylaxis, written by the BSACI, We'll put a link to this in the podcast notes. So moving on to something completely different. We're going to talk next about back pain. And Rhiannon, you have looked at a module that was written by Dr. Louise Warburton.
Yeah, I have. So the key thing for us today is thinking about when back pain would be regarded as an emergency. So, of course, GPs see lots of cases of back pain, and this module does cover assessment and remote assessment, use of the Start Back tool, and some tips on management. So it's very relevant to primary care. But the main emergency to be aware of is cauda equina syndrome. It's very rare, and hopefully you won't ever see this, but it is important to recognise should you come across it.
Okay, so for a GP, how rare is rare?
Well, the chances of a GP actually seeing a case are quite slim because it affects 6 to 10 per million population, according to the British Association of Spine Surgeons. But it's really not one you want to miss if you do happen to see one of those cases.
And what is cauda equina? Sounds like something to do with horses.
Exactly. Well, the equina bit of the name comes from the fact that cauda equina is a nerve collection at the base of the spine, which was originally described as looking like a horse's tail. So compression of the cauda equina can occur, for example, if there's a sudden large disc prolapse, and this compression can produce long-lasting effects with loss of bowel and bladder control and paralysis if not treated. So this is an emergency to rule out. And to rule it out, you could ask the patient about bladder and bowel function, any recent changes, ask about loss of sensation between the legs and around the anus, which is a significant symptom and would be uncommon in normal acute back pain. Can the patient tell when their bladder is full? Can they feel when they're passing urine? If they're not sure about any of these, then a physical examination would be required. So red flags include severe or progressive bilateral neurological deficit of the legs, recent onset urinary retention, recent onset fecal incontinence, perianal or perineal sensory loss, or unexpected laxity of the anal sphincter. Another cause of back pain that would be an emergency is spinal fracture, and this is more commonly seen in individuals with osteoporosis and older patients, particularly women. It may result from trauma, but Dr. Warburton says in this module that the amount of trauma involved can be really quite minimal. It could be even something as simple as picking up a heavy shopping bag.
Just shows that the risk of ordinary activities are totally different if you have osteoporosis or are very frail.
Absolutely, yeah. Topic for another day, I think. But red flags with spinal fracture include the sudden onset of severe central spinal pain, which is relieved by lying down. A history of major trauma, such as a road traffic collision or minor trauma, or even just strenuous lifting, as we've just mentioned, in people with osteoporosis and those who use corticosteroids. You might see a structural deformation of the spine, and you might find point tenderness over a vertebral body. So another emergency cause of low back pain would be infection. So infectious causes include discitis, vertebral osteomyelitis, or spinal epidural abscess. And I'll list some features in a minute, but if any of these features are present, then patients will need face-to-face assessment on the same day. So the things you're looking for are fever, tuberculosis or recent urinary tract infection, diabetes, a history of intravenous drug use or HIV infection, use of immunosuppressants, or a person who is otherwise immunocompromised. And finally, an urgent presentation, although not technically emergency, would be cancer, which can be a cause of a patient's low back pain. Obviously would require a 2-week wait referral. So red flags for cancer include the patient being 50 years of age or more, symptoms that come on more gradually, and the nature of the pain. You might get severe unremitting pain that remains when the person is supine, aching night pain that prevents or disturbs their sleep, pain aggravated by straining, for example, when going to the toilet or when coughing or sneezing, and thoracic pain. You might see localized spinal tenderness, and you might find that the person doesn't get better, or their symptoms don't get better after 4 to 6 weeks of conservative low back pain therapy, which might make you think that something else is going on.
Okay, so like you were saying, GPs will see a lot of patients with back pain, but cancer is something they should have in mind if the patient keeps coming back with back pain.
Yeah, so Dr. Warburton reminds GPs to look out for unexplained weight loss, past history of cancer. She says that breast, lung, gastrointestinal, prostate, renal and thyroid cancers are more likely to metastasize to the spine.
Yeah, so well worth reading the whole module on back pain, but also bearing those 4 categories of causes of low back pain in mind. On to our third topic, again very different, and this concerns a different type of emergency, doesn't it, Dawn?
Yeah, so we're talking about an urgent need for contraception after unprotected intercourse. We have a module by Dr. Jill Jenkins that talks about the efficacy and safety of emergency contraception. It highlights contraindications and provides case studies for GPs and nurses to work through.
It's obvious to state, but there is clearly a public health need for those who need emergency contraception to get it.
Yes, as this module points out, the number of unwanted pregnancies has been falling in those under 18 years, which is good news. But across all age groups in 2021, there were more than 214,000 abortions provided for people living in England and Wales, the highest number since the Abortion Act was introduced. Nearly all of these were funded by the NHS. The decision to have an abortion is complex and a difficult one, and perhaps could be avoided with better access to emergency contraception.
So what are the options for emergency contraception? I'm sure the intrauterine device, or IUD, is one of them.
So there's 3 options. There's the IUD, there's 1.5 milligrams of levonorgestrel, or LNG, or 30 milligrams of uliperistrol acetate. I'm just going to say UPA from now on. Dr. Jenkins' module is based on guidelines from the Faculty of Sexual and Reproductive Healthcare, which were updated in July 2023, and looks at these options. An IUD is effective for up to 5 days after unprotected intercourse or after ovulation, and can remain in situ, offering continuous contraception for up to 10 years. LNG is licensed for use up to 72 hours after unprotected intercourse, but it has a continuing, although diminishing, protective effect even after 72 hours up to 96 hours. Historically, this diminishing protective effect was kind of a better than nothing reason to use LNG when the person presented after 72 hours and did not want an IUD. However, UPA is now licensed as a single oral 1.5 milligram dose up to 120 hours or 5 days following unprotected intercourse. UPA has been shown to prevent significantly more unplanned pregnancies than LNG when given within 72 hours, making it the oral treatment of choice for most women.
Can most people use any of these 3 options, Dawn?
So there aren't many absolute contraindications. People of all ages can use an emergency IUD, though it's not normally recommended within 28 days of giving birth. Most women can use UPA, although it's advised against in people with severe liver disease or severe asthma, or if they are taking certain prescribed medications. And most women can use LNG, although they may need some advice about dosages and efficacy if they are using certain prescribed medications. Timing is often the main factor in the decision of which emergency contraception to use. The IUD should be seen, according to Dr. Jenkins, as the best overall option, because it provides the best efficacy. But it's not accessible without a skilled clinician in the practice. And of course, a person is perfectly entitled to not want an IUD. There's a handy table in the module which compares all these different emergency contraception options. And also in the module, there's some interesting case studies. One of these is Shani. She's 24 years old. She's come to her GP because she's had 4 or possibly more episodes of unprotected sex in this menstrual cycle. She thinks these were on days 8, 10, 11 and 16 of her usual regular 27-day cycle. On day 8, she took a morning after pill that her friend got for her, but she doesn't really know what it was. She drinks heavily, has used cocaine and has some degree of liver damage. Question posed in the module include whether all options of emergency contraception are open to Shani or not. I mean, what do you think?
I think there was a mention of UPA being contraindicated in liver damage, if I remember correctly. So would that be unsuitable for her?
Dr. Jenkins states in the module that UPA is contraindicated in people with severe liver impairment. So a clinical assessment of Shani's current liver status would be essential. I mean, just to be clear, there is some degree of damage with Shani. We're not quite clear if it's severe. There wouldn't be time to organise testing, however, but there might be records of recent blood tests in her notes, so you do need to find this out before you give her UPA. But if Shani's liver status shows that she doesn't have severe impairment, UPA wouldn't be ruled out, and LNG and an IUD would still be options. The next question is whether emergency contraception is going to be effective given all the episodes of unprotected intercourse. What about this point?
I would guess that the IUD would be the only option that would be effective for her.
Yeah, you're right. Only the IUD will cover all of the episodes of unprotected intercourse. Shani would be expected to ovulate on day 13, and it's now day 17, so it's 4 days after ovulation. However, Shani may not want to have an IUD fitted, so UPA or LNG are still options to consider, again, providing with the UPA her liver function is okay. It's not advisable to use the UPA more than once in any given menstrual cycle, but Dr. Jenkins feels it's more likely that she may have got an LNG pill, from her friend, as these are more accessible. However, the oral options of LNG or UPA would not extend back to all of the episodes of intercourse.
Yeah, it's really interesting to hear about the nuances of this, because I think there's a lot more to it than I would have thought. So does the module then go on to talk about what's the best thing for Shani going forward?
Dr. Jenkins makes the point that people will need support in making informed decisions, and Shani is likely to need ongoing review and advice. Such advice could include using long-acting contraceptions in the future, but in the short term, Shani may choose other methods. So to recap, this is a very interactive learning module, and it's well worth taking a look to consider the action you would take in this case and the other cases featured in the module.
Brilliant. Thank you, Dawn. We have more about emergencies on the MIMS Learning site. There are lots more red flag modules, as I mentioned. We recently covered some red flags and emergency presentations around pregnancy in a podcast episode on pregnancy challenges. And we've also got a module on gynecological emergencies written by consultant urogynecologist Mr. Abdulmajid Abdulrahman. So thank you so much, Dawn and Rhiannon, for discussing emergency care with me today. What have we learned today? Here's a quick recap of some of the take-home points from our discussion. First, on the topic of anaphylaxis, recommendations from the Resuscitation Council UK did change in 2021, so make sure you're aware of these changes. A key change is that the new guidance emphasises that administering intramuscular adrenaline is the most important step in treatment of anaphylaxis, and it also stresses the need for repeat dosing of adrenaline in those who don't respond to the first dose. Second, when it comes to presentations of back pain, as part of your assessment, don't forget to have 4 key things in mind. Firstly, cauda equina in those with bladder or bowel problems or loss of sensation. Vertebral fracture in those with a history of trauma or osteoporosis. Cancer in older people and those with severe unremitting or night pain. And infection in those with fever and the immunocompromised. Thirdly, there are 3 key options for emergency contraception. The IUD is highly effective, but may not suit everyone. So ulipristal acetate is a good oral option that can be used up to 5 days after unprotected sexual intercourse, providing there are no contraindications. Don't forget you can claim CPD hours for listening to these podcasts, and there are plenty more on the MIMS Learning website. Thank you very much for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. We've got 2 more episodes before the end of the year, I believe, and we'll be covering chronic cough and a roundup of the highlights of 2024. We'll see you again soon.